Good afternoon, everyone. We'll just give folks another minute or so to join, and then we'll get started. Good afternoon, and welcome everyone to Transfusionist Talk, Transfusion Made Bloody Easy. My name is Donna Berta. I'll be talking with you today, and my coworker Sheena is in the background, keeping everything running smoothly. Our topic for today is minor transfusion reactions, maybe not so minor. We'll start with the land acknowledgement. As we gather, we begin by acknowledging that this virtual event is hosted from the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish One Spoon Wampum Agreement. Please acknowledge and reflect on the land where you are joining. So as you've noted, the event is being recorded, and by participating, you're giving your consent. Excerpts from this may be used for educational purposes. I don't have any commercial product conflicts of interest to declare. I am a member of several transfusion-related committees, and I do want to point out that all patient case information is fictitious and has been fabricated for this learning. The presentation is being recorded. It will be posted along with the slides on the OrbCon website. If you go to that OrbCon website, that link, and then go to resources and then presentation library, you then can scroll down and find the Transfusionist talk. If you have any questions or comments during the presentation or at the end, you can go to the Zoom chat function and type in your questions there. If there are more questions than the time permits, the answers will be posted with the recording. I'm going to be asking you some questions throughout the presentation, and so just to make sure we're all up on the polling technology, we'll do this practice question. And so it looks like we have a good mix of folks attending today. That's great. Hopefully everyone was okay with the polling. Okay. Sorry, some technical challenges here on my part. As is customary with this event, we'll go through a couple of questions that I'm going to ask you at the beginning, and then hopefully the answers will become very obvious throughout the presentation, and we'll go over them again at the end. So this first question, characteristics of minor transfusion reactions include, and you can select more than one if you feel more than one is applicable. Usually reactions are self-limited, and the transfusion can be restarted as long as the blood is in date viable. Option B, the incidence has decreased over time based on advances in blood manufacturing strategies, nonetheless remain the most commonly occurring transfusion reactions. Are uncomfortable and unpleasant for patients. Medication to alleviate the symptoms is often administered. And reaction reporting to TML or the blood bank is not required given the non-serious nature of these reactions. So I'll give you another minute or so there to answer. Interesting. Okay, and we will come back to that question again later in the presentation. And the second question for you, Barney is a 62-year-old. He had some heart surgery. He's doing well, but his hemoglobin is 62. So a 1-unit red cell transfusion is ordered. He has no previous history of any blood transfusions. So appropriate pre-transfusion medication for Barney to prevent a minor transfusion reaction includes, and you can select more than one answer if you feel that's the best option. Okay, that looks interesting as well. And as I mentioned, we will come back to those. So my objectives for today, hopefully that you will be able to understand the etiology and pathophysiology of minor transfusion reactions, at least what is known about them. Look at the nursing actions to care for patients who are having these minor reactions, and also to have a discussion of the questions that you submitted. I want to thank you all for submitting some very interesting questions when you did your registration, and I will try to cover most of them throughout this talk. So whenever I'm talking about transfusion reactions, I like to show this detective cartoon. In approaching transfusion reactions, that's exactly what you have to be, is a detective. You want to use your critical thinking and problem-solving skills, and it is very important to keep your approach in context. So what is the patient's other diagnoses, other conditions, what's going on clinically at this point in time that may impact this? So hopefully you're in detective mode now. There are several standards that are out there that in Canada that guide transfusion medicine and particularly transfusion reactions. There's the Canadian Standards Association document of standards. The Canadian Society for Transfusion Medicine also publishes standards. Accreditation Canada, the hospital accreditation process, also has a transfusion services standard with guidance there. And then Accreditation Canada Diagnostics, or ACD, also has an accreditation program that medical laboratories can participate in. And all of these standards, they all do align and have the same requirements, similar requirements. The one that I go to most often is the CSTM one. It is specifically for hospital transfusion services, and I really appreciate the way they have their standards set up. They all have as their verb, their standard statements, shall, should, or may. And shall means that the standard is mandatory. If you don't do this, you are not meeting current acceptable practice for transfusion medicine. Shall is more of a should is more of a recommended standard where it is scientifically valid, but it's not mandatory. And then may is something that is valid, but it's to be used at your lab leadership's discretion. So what do these standards say about transfusion reactions specifically, particularly the patient care part? And I'll just point out the superscripts that are here, the numbers, they pertain to the pertinent clauses that align in the CSA standards. So that's what they're all about. So the CSTM standards, they tell us that we must have documentation, reporting, investigation, follow-up, policies and procedures. We also need to have policies and procedures to manage potential reactions. They also say we need to have a list of the signs and symptoms so that everyone is aware, both nursing and the transfusion service. And also they indicate that all adverse reactions must be reported to the transfusion service, serious and unexpected ones more immediately. And it does give a listing of some of the serious ones, but this is not necessarily an inclusive list. So what we need to do is fairly clear there. In terms of a policy and procedure, every hospital has one. This one is the Ontario Transfusion Transmitted Injury Surveillance System reaction chart or guidance for managing transfusion reactions. And I tend to use it because I'm not affiliated with one hospital in particular, but more province-wide. And it is a 2-page document. The talk today is going to pertain mostly to the blood components, red blood cells, platelets, and plasma. The blood products that are manufactured from plasma, there can also be reactions to those as well, but they're listed more in the product monographs and can be a bit more varied. So we'll move right into our patient case. This case is about Pebbles. She unfortunately has acute leukemia and will require chemotherapy. The oncologist has discussed the role of blood transfusion. She is overwhelmed and is asking, what are the minor transfusion reactions? I remember they're quite common, but not very serious. So in terms of having a discussion with Pebbles, which are the minor reactions that we should be focusing on? Is it transfusion-associated circulatory overload, a mild fever feeling chilled, a bacterial infection that's treated with antibiotics, or hives, a rash, or itching? Okay, and it looks like everybody is pretty certain about what those minor transfusion reactions are. Indeed, the correct options are a mild fever or feeling chilled, and hives or a rash or itching. One of the questions that you posed to me when in the registration documentation was about the timing of signs and symptoms. So I put together this little chart to help deal with that. And so they're categorized under the 4 major signs and symptoms. So fever during or up to 4 hours after the transfusion is completed. Urticaria is the same. The dyspnea or respiratory reactions, there is more variability in the timing. Again, during, but up to 6 hours for trolley, 12 hours for taco, and up to 24 hours for TAD. We're not going to talk about these today. They're outside of the minor transfusion reactions, but just to give you some guidance. And then the final listing, hypotension. I did find some variability here. In the TTISS chart, it says during or up to 4 hours. The Canadian Blood Services website also, their guidance document says up to 4 hours. In Bloody Easy 5.1, the book that we put out, it does say up to 1 hour. And there is also guidance from the International Society of Blood Transfusion that says up to 1 hour, during or up to 1 hour after completion for hypotension. I think you have to take that with a bit of interpretation, because certainly, for example, trolley, hypotension can be a feature there, but it's during or up to 6 hours after. So there may be some interpretation, and certainly there is some differences in the duration guidance for that, for hypotension particularly. So our minor transfusion reactions, we'll talk about fever first. So fever is defined as a temperature of at least 38. And the temperature also has to be an increase of 1 degree from pre-transfusion, and or it could also include shaking chills or rigors. Fever is further divided into low-risk fevers and high-risk fevers. The low-risk fevers are our minor transfusion reactions, and that's a temperature of 38 to 38.9, but no other symptoms, just the temperature. If somebody is subjectively saying that they feel chilled or cold, that could also be part of a low-risk fever. The other thing that's unique to this minor reaction is you might be able to restart the transfusion depending on how things progress. In contrast to the high-risk fevers, where the temperature is at least 38 and there are other signs and symptoms, or the temperature is 39 or greater, or the patient has actual shaking, chills, and rigors. And for these high-risk fevers, again, not in the scope of today's presentation, those we would not restart the transfusion. When we're talking about other signs and symptoms, what do we mean? I put together this little chart from the TTISS chart and also extrapolated some from there. We've already talked about fever, about temperature. That's what the significant values are there. For hypotension, the significant value is a systolic blood pressure less than 80 and a change from the pre-transfusion systolic blood pressure of greater than 30 or a 15 to 25% relative decrease. For pulse and respirations, they don't particularly give any guidance in the chart. Generally, in the healthcare world, a pulse greater than 100, respirations greater than 20 are considered significant. And I've added the part from pre-transfusion of 15 to 25% relative increase. Oxygen saturation is detailed specifically, a saturation less than 90% or a decrease of at least 5% from pre-transfusion O2 sat. So for example, if the patient's pre-transfusion O2 sat was 97 and it dropped to 92, that would still be a significant value to consider. So this chart may be something that you find helpful to have some particular guidance, and it may be something that you can ask your transfusion service to look at creating something specific for your hospital. The other signs and symptoms are very varied in terms of what can be associated with a transfusion. They're the four major ones where we categorize transfusion, but then any of these other things that are listed in alphabetical order could be also indicative of a transfusion reaction. I do want to mention, because this again was a question, a pre-transfusion fever related to the patient's underlying condition, that is not a contraindication to initiating a blood transfusion. If the patient truly needs a transfusion, their hemoglobin is low, they're symptomatic, then you go ahead and give the transfusion despite the fever. It does make monitoring the patient a little more challenging. You have to monitor them very closely, maybe more frequent vitals and assessments, as well as a slower rate of transfusion because they have that underlying fever. And you would give them their Tylenol for the fever or whatever they're receiving to treat the fever. You would give those medications as they had been ordered. So can be done, just makes it a little more challenging in terms of the monitoring. We'll go back to Pebbles now. And another question for you. She's midway through her course of chemotherapy. She has required red cell and platelet transfusions. No reactions, though. At this point, her platelet count is 6, and she's to have a dose of platelets over 1 hour. 15 minutes after the start of her transfusion, the patient check, her temperature is 38.3. 30 minutes pre-transfusion, her temperature was 37.1. Her other vital signs are unchanged. So in looking after Pebbles, the first thing that you should do at this point in time when you see this temperature change, your options are, and again, here we're just in this case, we're just picking one. Your options are call the prescriber, stay with Pebbles at the bedside, monitor her closely, stop the transfusion, check her armband identifiers to make sure they're identical on the platelet bag. Okay. And so overwhelmingly, we have the correct answer, stop the transfusion. I had a lot of questions about, do you always have to stop the transfusion? And yeah, you really do always have to stop it. And that's because you don't know what's going to happen and you don't know where you're at. Is this going to be a minor reaction or is it going to escalate to something else? So you do have to stop the transfusion. That's always the first thing that you want to do. This is taken from Bloody Easy Blood Administration. This is the list of actions to follow. And again, always stop the transfusion. You want to keep the IV patent. You do want to stay with the patient at their bedside. You want to watch them closely. You want to do a set of vitals to get more information. You want to rule out what you can in terms of an identification error. You do want to talk to the prescriber and come up with a plan and then follow through on that plan. You will need to report the reaction to the blood bank and you will need to document according to your policy. But always the first thing is stop the transfusion. So the etiology, pathophysiology of these low risk fevers, we don't know for sure. This is a thought to be scenario. It's felt that it's related to an accumulation of inflammatory cytokines. Cytokines are a signaling molecule and they promote inflammation, and that they are in the plasma part of the blood components. The cytokines are produced by the leukocytes, by the white cells during storage. There's also a thought that the patient may have antibodies that react with antigens that are expressed on the cells in the blood component. And those cells are usually the white blood cells, the leukocytes. So you can see from what we're thinking about these low risk fevers, it's related to the white blood cells. And that thought has been known for a while. And so much, in fact, that in 1999 in Canada, Canadian Blood Services, CBS, implemented universal pre-storage leukoreduction. And so what that means is after the blood's been collected from the donors, it goes through a special filter to remove the majority of the white blood cells. There are still some residual white blood cells in all of the blood components, but markedly decreased from what it was without the leukoreduction. They also have in Canada more recently in 2022 for platelets, they have implemented a platelet additive solution. And so this is a nutrient media to suspend the platelets in. Prior to this, they were suspended in plasma. So now the ratio is about 60-40. And so there is much less plasma in the platelets at this point in time. Platelets also are unique in that there is an awareness of microparticles that occur during storage, and they release inflammatory cytokines. The role of them is not fully understood, but it is felt that they contribute to platelet low-risk fever reactions. The low-risk fever is a diagnosis of exclusion. So you do have to have your detective hat on and you have to watch for any evolving or lack of evolving symptoms and then rule in or rule out other things depending on what else happens. But as we've said in the original definition, it's a fever less than 39 and no other symptoms is what you're looking at to get to this conclusion of a low-risk fever. These events are benign. They don't have any impact on the patient's health. And the frequency. This information is from Bloody Easy, and the 2022-23 version for platelets, it's 1 in 100, the frequency. Previously, from the data that was available in 2016, the platelet likelihood was higher and being 1 in 20 transfusions. And for red cells, it's remained the same, a little bit lower incidence than for platelets, again, likely related to the amount of plasma, because your average unit of red cells has about 29 mils of plasma. Platelets with the additive solution, the current platelets that we have, it's about 75 mils of plasma in a unit. So we'll go back to Pebbles now. So her transfusion was stopped, saline's infusing, all of the checks, the identification and unit number checks, everything matches. Another 15 minutes have gone by. There have been no other symptoms, and her temperature is still sitting at 38.3. So what is the prescriber likely to order for Pebbles? Acetaminophen, diphenhydramine IV, just monitor her closely for the next half hour, or cetirizine PO. And again, here you can select more than one. I'll give you some time for that. Okay, so it looks like most people have replied, and indeed, monitoring her very closely is always a good thing to do. In terms of the medication, the acetaminophen for the fever is the medication of choice. The antihistamines, diphenhydramine or cetirizine, they have no role in a fever, so they would not be considered, and we'll talk a little bit more about that. So when you have a low risk fever reaction, the critical step again is monitoring the patient closely, searching diligently for anything else that might be going on. And that has to be if the transfusion is restarted during the transfusion, and then for 4 hours afterwards, you want to keep a close watch because things can evolve. You want to look at, does the patient have any history of fevers? Have they had fevers? Have they been receiving acetaminophen? The acetaminophen is indicated to give that to treat the fever. And then half an hour to an hour after that, you want to see if the temperature is stable or decreasing and no other symptoms have evolved. The prescriber has an order and the blood is still viable or in date. Like the transfusion has to be completed within 4 hours of the time of issue from blood bank, or you can't transfuse that blood to the patient. So if all those criteria are met, then you can cautiously and slowly restart the transfusion. And you would restart with at that slow rate, the 50 mils per hour for 15 minutes, and recheck the patient. That's how you would restart the transfusion. And it depends a little bit, and I do want to say there is no known evidence supporting an antipyretic and antihistamine being given but we do see that being given together as a so-called cocktail. That's a historical practice that has gone on. When you're thinking about restarting the transfusion, you also have to think about how much of this unit of, let's talk about a unit of red cells, for example. So if the patient's gotten 3/4 of the unit of red cells, you might think that, well, maybe I really don't want to, I'm not so worried about that last little bit, so I'm not going to, the prescriber may not want to give it. It all depends. You have to think about as well, if you've only started giving the transfusion, like in this example with Pebbles, only a little bit has been given. Do I really want to expose this patient to another donor, another unit of blood? So you may want to then, you might be a bit more inclined to retry to continue transfusing that unit versus expose them to another one. And who knows what would happen there. So it's not a cut and dry thing to do. It just depends on the clinical scenario. We'll go back to Pebbles again. So she had her transfusion, her platelet transfusion after the acetaminophen. The remainder of the transfusion was uneventful. Now she needs a red cell transfusion. Her hemoglobin is 62. And so what should be done in terms of a pre-medication to prevent recurrent low-risk fever reactions? Would you give her acetaminophen prior to this red cell transfusion? Would you give diphenhydramine? Would you not worry about giving any pre-medication, or would you give cetirizine, another antihistamine? I'll give you a moment to reply there. Okay, so it looks like most people have said to give Tylenol before this next transfusion. Some people have also said that premedication is not indicated. The antihistamines, diphenhydramine or cetirizine, they would clearly not be indicated. They don't have any role in fever, treating a fever or trying to prevent a fever. So you would not want to give those. And we'll just talk about the answer of choice would be, for me, would be that pre-transfusion medication isn't indicated just yet. And I'll talk about that with the next slide. So pre-medication practices began about 75 years ago, and lots has changed in terms of blood manufacturing and storage, and the reaction risks have decreased. There still persists that assumption that a reaction is going to happen, and also a historical thought is that the risk of a reaction outweighs the risks associated with too much or inappropriate pre-medication. But the evidence, the studies that we have out there, do not show that prophylactic Tylenol will decrease a low risk fever reaction. So there's no benefit to giving everybody Tylenol before we give them a transfusion, because it's not going to be a benefit. As well, the evidence has shown that if you have a recurrent, you're trying to prevent a recurrent low risk fever reaction, acetaminophen has not really been shown to help there consistently as well, though it is quite often, we see that it is being used. I did find when I was researching this topic, there are several studies out there, and this one in particular, by Hole et al., was a very interesting QI project where they decided that they would only give premedication after 2 or more reactions to any type of blood component. And they had an evidence-based algorithm that they built into their electronic order set to guide pre-medication use. And it's a very interesting read. They did find that this was very beneficial in decreasing pre-medication. The other thing that they also did was they created something that they describe as a transfusion note, where they had a way of clearly documenting what reactions the patient had had and what the pre-medication plan was. So it's a very interesting read and something that you may want to consider if you're looking for a QI project. For significant and recurrent low-risk fever reactions, there are some alternatives that can be considered. Giving steroids as a pre-med, using fresher components, removing the plasma from the components, taking the plasma off before you transfuse, or you can also wash red cells, and then you wash them with saline through a centrifuge and then resuspend them in saline. Platelets, that doesn't work so well. It really damages the platelets, so it's not something that we encourage. But again, the efficacy of all of these alternatives have not been established. But if a patient is having a fever every time they're needing blood, and they're a patient who's going to need blood frequently, these practices are used. We'll turn our focus now to talking about minor allergic reactions. So that's defined as hives, a rash, or itching, and no other symptoms. So if it's less than 2/3 of the body, then it's considered a minor allergic, and you might restart the transfusion. Some hospitals have a category of minor allergic extensive reactions where there are no other symptoms, but it's 2/3 or more of the body. And in those cases, you wouldn't restart the transfusion. This chart is taken from Bloody Easy Blood Administration, and it just outlines what percentage of the body surface area it is, because you might think, oh, well, if they've got a rash on their chest and both arms, that's more than 2/3. But in actual fact, in an adult, it isn't. That's only 36% of body surface area. So the chart can help you with figuring out those kinds of decisions. Again, for minor allergic reactions, the pathophysiology is not completely understood. Again, it's felt that it's related to the plasma part of the component, could be exposure to specific plasma proteins. There are also numerous cases documented where a food or chemical allergen has been ingested or inhaled by the donor. And then when that blood is transfused to a patient who has that particular allergy, they have gone on to have significant, in some cases, anaphylactic reactions. So there is some thought there. It's also been hypothesized that there are some allergen-independent pathways, and the inflammatory cytokines may have a role in triggering these allergic reactions as well. But again, not clear what really causes them. The frequency hasn't changed over time in the last 10 years or so, but they do happen quite often. 1 in about 100 transfusions is the likelihood. We'll talk now about another patient. So this patient, Robin Hood, he was in a motor vehicle collision, very significant one. He's otherwise healthy, but he does have multiple food allergies. He required care at a trauma center. They used the massive hemorrhage protocol, and in total, he received 40 red cells, 20 units of plasma, 4 doses of platelets, and 12 grams or 3 doses of fibrinogen concentrate. He was stabilized and then went to the ICU. And when he got there, they noticed that there were hives on his entire left arm and his back. The hives subsequently resolved. Today, that was yesterday, today, Robin's needing to have some major surgical procedures to stabilize some fractures. His pre-op INR is 2.6, and an order for plasma, 4 units transfused each over 1 hour, has been placed. So appropriate pre-medication to prevent a recurrent minor allergic reaction in this patient includes, and again, our choices are acetaminophen, PO, diphenhydramine IV, no pre-transfusion medication is indicated, or cetirizine PO. Sorry. This one is a bit trickier. Okay, so most people, it looks like, said they would favor either giving the diphenhydramine, the Benadryl IV, or the pre-transfusion medication is not indicated. And it really is kind of a toss-up. In terms of the acetaminophen, there would be no role for that in a minor allergic reaction with hives because it's an antipyretic. The cetirizine is an antihistamine, but it's oral, and it's doubtful that this patient would be having an oral medication at this point in time. In terms of the diphenhydramine IV, yes, he did have hives after multiple transfusions the previous day. We have no ability to know which transfusion that was associated with. If on reporting that to the blood bank, you would have to list all of those units and products that he received. Now he's going to the OR for a lengthy procedure. In the OR, there are going to be drapes all over him. It's going to be difficult to watch for hives or a rash. So you might want to give him the diphenhydramine. It really is a bit of a challenge and depends on the clinician and maybe how stable he is otherwise. If you want to be giving IV diphenhydramine, because one of the side effects can be some hypotension. So it would be the prescriber's decision, and it could go either way. Okay, we'll move on to our next patient case. And so this pertains to IVIG, an IVIG reaction. So this patient is Wilma. She has a chronic neurological condition called CIPD. She has been long-term receiving IVIG, 70 grams every 5 weeks. She's been doing well. She's never had any reaction or problem with her IVIG. At her last treatment, the brand was changed related to some supply chain issues. And at the very end, after she had received the 70 grams, she noticed a cluster of hives on her right arm, right near the IV site. This resolved spontaneously. The hives didn't come back. Today is her next IVIG treatment, and it's been decided that they would avoid that IVIG lot number that was associated with the hive reaction. And so what would we do for Wilma in terms of pre-medication? Would it be acetaminophen, diphenhydramine IV? Pre-transfusion medication is not indicated, or the cetirizine. And I'll give you a moment to. Okay. Very interesting. Most people said, and I would agree, that pre-transfusion medication is not indicated at this point in time. You might be tempted to give her some antihistamine, diphenhydramine, or cetirizine, but we've changed the lot number, and so it would be worthwhile to see if that makes the difference and if she's going to be okay with that. Because if we give her antihistamine with and change the lot number, do two things, we aren't really going to know what caused her to have hives again or not have hives again. And so we might be signing her up to always having antihistamine before IVIG. So I think it would be worthwhile just to not give her any pre-medication and see what happens. But again, the prescriber's judgment would be involved in that scenario as well. So I want to talk to you a little bit now about antihistamine treatments for minor allergic reactions. Benadryl, there's a dose range 25 to 50 milligrams. It can be given PO or it can be given IV. It has a long-standing historical use. It's a first-generation antihistamine. However, the side effects are quite common and they can be quite significant. Like people who are given diphenhydramine are to avoid driving because it can have a sedative and cognitive impairment effect. It can also be used as a sleep aid, and in fact, does just the opposite. It can cause poor quality sleep. It can cause dry mouth, dizziness, and orthostatic hypotension. It also does have poor histamine receptor selectivity, and it can bind to cardiac potassium ion channels. That can lead to a prolonged QT interval, and that increases the risk of ventricular dysrhythmias, including ventricular fibrillation, and that can be potentially a life-threatening event. It also does cross the blood-brain barrier, and that can lead to significant central nervous system suppression. It can cause psychomotor impairment. It can cause coma, even death. So significant side effects. Other thing about Benadryl, it's been available since 1946, and that is well before current licensing standards. So Benadryl was never subjected to the rigorous safety and efficacy standards that would be required today to have a drug be approved to be put on the market. It is a very low cost medication, and that may be a barrier to use of some of the newer generation antihistamines. The newer generation antihistamines, they have been around for a while as well, available since the early 1980s. They have been deemed much safer. They've been studied. There have been high quality randomized controlled trials with them. They work very well. They have a faster onset of action, and they do have some side effects as well, but not as significant as the ones associated with Benadryl. So the Canadian Society of Allergy and Clinical Immunology, or SASI, they actually in 2019 published a position statement recommending these newer generation antihistamines over the older ones. because of the side effect profile and the CNS and cardiac issues that they had caused. And they have gone on, and that was specifically for allergic rhinoconjunctivitis and urticaria. They have gone on to extend this recommendation to all antihistamine indications, including allergic transfusion reactions. And I have listed here a link to the president of the Sassy did a presentation for transfusion medicine rounds last September, and it's archived on the OrbCon website just about this and about their recommendations. So some hospital transfusion medicine services may have adopted this approach already. It certainly is something that I would suggest is worthwhile to bring to the attention of your transfusion medicine medical director and look into. So again, with these minor allergic reactions, the critical step is watching the patient very closely, looking to see what happens if there are any more signs and symptoms during the transfusion or for that 4 hours after. I would suggest a newer generation antihistamine when a reaction occurs. And then after the antihistamine has been given, again, if the rash is or hives or itching is resolving, there aren't any other symptoms, the prescriber's has ordered it to be retried, and the blood is or the product is viable or in date. So for IVIG, it would be 4 hours from the time that that particular bottle was spiked if you were going to restart it. Again, you would restart cautiously and slowly. And again, there is no evidence supporting giving Tylenol and antihistamine together, although it is seen quite commonly. Pre-medication practices. Again, this is the same information that I shared with you about the low-risk fevers. They've been around for a long time. People are still thinking that the risk of a reaction outweighs giving the too much or an inappropriate pre-medication, but the evidence is the same. There is no evidence to support giving prophylactic antihistamines, so we shouldn't give everybody an antihistamine before a transfusion to prevent these minor allergic reactions. As well, for recurrent minor allergic reactions, antihistamine has not been shown to decrease them, though it is quite often used in that manner. Again, this article with the Quality Improvement Project did include both types of minor allergic reactions, or both types of minor transfusion reactions, the low-risk fevers and the allergic reactions in their algorithm, and again, something to consider. If you have significant and recurrent minor allergic reactions in a particular patient, the alternatives are to plasma deplete the components or to wash the red cells. Again, efficacy of those alternatives has not been established. I want to ask you one more question about transfusion. So what medication must be available whenever blood is being transfused? Antihistamine, corticosteroids, epinephrine, or broad-spectrum antibiotic? Okay, it looks like those who wanted to cast a vote have done so. And the correct answer would be epinephrine. With transfusion, an anaphylactic reaction can occur, and you do want to have epinephrine available. Your steroid or your antihistamine, if you're having a true anaphylactic reaction, you would go straight to epinephrine. So you do need to make sure that epinephrine, you know where you can find it if you're going to be transfusing patients. And now we'll talk a little bit about the investigations. For these minor reactions, by their definition, since they're minor, they don't require any further testing or investigations. other more major, more serious reactions, there's lots of investigations that need to be done, and they're listed on the reaction chart. And that would be another talk to talk about those major reactions and what investigations and things would be required. Documenting and reporting all transfusion reactions, including the minor ones, must be documented as per your hospital's policy and procedures. And again, they have to be reported to the blood bank. The speed and urgency of reporting is not as great with these minor reactions, but nonetheless, they should be reported. If minor reactions were not reported to blood banks, would Canadian Blood Services have gone ahead and changed how platelets are manufactured and gone to less plasma in platelets if all those reactions hadn't been reported and the data was not there to suggest we needed to do something? So reporting is very important. Your blood bank does have obligations in the standards for reporting some of the more serious types of reactions to Health Canada or back to Canadian Blood Services, or if it's a blood product, to the manufacturer. So you do need to help them out by always reporting these reactions to them so that they can do the further reporting that's indicated. And now we'll go back to the two questions that I asked you at the beginning and just talk about those again. So characteristics of minor transfusion reactions include, I'll let you go look those over and okay, it looks like most people who wanted to vote have. And yes, they can often be restarted, but cautiously, the incidents, it has decreased, but they are very common. They are unpleasant for the patient, but we can give the patient medication when these reactions occur. And D is incorrect. They all have to be reported to the blood bank, serious or not serious. Okay, so we'll move on to the other question about the patient who had the cardiac surgery and no history of transfusion reactions, and what pre-medication would we consider there, if any? And I believe those who have wanted to vote have done so. And as the poll indicates, the correct answer is C. There is no indication for pre-medication in this scenario. This patient has never had a transfusion, let alone a reaction, so there is no role for pre-medication in his care. I do want to pause now and share some other news with you, and that's regarding the TTISS and also the TESS program, the Transfusion Error Surveillance Program. These programs were put into place following the tainted blood tragedy that occurred and Justice Creever's recommendations. And it has been announced that they are going to withdraw the funding from these programs as of March 31st, 2026. And so the transfusion community certainly sees this as a tragedy because it takes away our reporting and compiling of transfusion reactions. If this went ahead and proceeded, Canada would be the only developed country without a hemovigilance system or a tracking of transfusion reactions. And in my opinion, that would be an equally great a tragedy as was the tainted blood scandal if we went backwards to that. So there is a petition. You can click on the link or use this QR code to sign the petition, and I would encourage you to do so and encourage you to pass this information on to the public and to others. There is information on the OrbCon website about this as well. So I will leave that with you. I do have several references for you. I have to thank the Ministry of Health because they provide our funding for the OrbCon program. Thanks to my OrbCon and Transfusion Medicine family for their mentorship and support. Thanks to Sheena and to Dr. Roos for their expertise. Thank you for the questions that you provided and for your attention. I will point out that our transfusion medicine boot camp for nurses is going to be November 26th. A save the date will be coming out next week, and registration is going to open in October. We are going to have more transfusionist talks next year. There is some dates there for you. And if you do have any questions, certainly you can email me, or we'll have a few moments for questions just after this. And this is the link to the evaluation survey. When you complete that, you can complete the survey, then you can get your certificate. And it's also a good way for you to give me feedback in terms of what you would like to see for future topics. And I will stop there now and see if Sheena, if we have any questions in the chat that anyone wants to ask, or if you want to submit a question, there is a few minutes for that still.
There's currently none in the chat right now, but we can give it a couple
Sorry, I
minutes.
don't understand.
Oops, sorry. We'll just give it another minute or two to see if there are any questions. Okay, well, if there are no questions, then we can stop there. I'll give you a few minutes back to your day. And certainly if questions come up, you can always use email to voice any concerns that you have. I hope the presentation was helpful, and enjoy the rest of your day.